Hello, and welcome to Breast Cancer Conversations, a podcast brought to you by survivingbreastcancer.org. I am Laura Carfing, breast cancer survivor and founder of survivingbreastcancer.org, a nonprofit organization providing community, education, and resources to empower those diagnosed with breast cancer and their caregivers from day one and beyond. Hello, my friends, and welcome to another episode of Breast Cancer Conversations. I am so glad you are here. If this is your first time tuning in to our podcast, I want to give you a huge virtual hug and welcome you. I know I said this in my intro, but our podcasts are produced by survivingbreastcancer.org. So if you are looking for additional resources, we have virtual support groups, we have virtual art therapy classes, expressive writing, we produce blogs, we have a newsletter, like so much going on. So feel free to head on over to survivingbreastcancer.org/events to see our full lineup of programs and services absolutely free to you. Today, I am really excited because we're going to talk about all things plastic surgery. I have the pleasure of speaking with Dr. Francel, and we are just going to dive right into all things breast cancer. Welcome to the conversation. You are a board-certified plastic surgeon. You have established your own private practice, and you are clearly distinguished in your field. Your medical journey began with training at Harvard Surgical Services, followed by specialization in plastic surgery at Johns Hopkins Hospital. You have presented at 20 national and international plastic surgery conferences. And what I love, your passion, which extends well beyond just the operating room in plastic surgery. You really focus on the education and empowerment and the compassionate care you give to your patients, which is just so reassuring.
Well, I do like to get very involved in my patient, very involved in their care, even after I get done doing my surgery. It is something that's, like I said, always been deep in my heart that I want to take care of them. I'm kind of older. So actually, I remember back when I was in my general surgery at Mount Auburn Hospital in Boston, the patients would go in for a breast biopsy and they would not know if they were going to have a mastectomy when they woke up. Very devastating. They had a lump in their breast. They said, okay, we need to take it out, do pathology. They would do a frozen section, and wasn't unusual, 10% of the time to go on to do a mastectomy at the same time. That was heartbreaking for me. And then as I got a little bit more into the plastic surgery aspects, it was nice because then I could see being involved in their care right afterwards and allowing them to get back to a natural breast that they had before they had the cancer. Huge part of what my career has been. Back in my heyday of breast cancer, I was doing probably about 70 to 80 a year. Since I'm kind of older now, I do about 4 or 5, but they're usually patients who have had reconstructions and have had some type of disaster problem. And so they get referred to me. About 30% of my practice are revisions of other people's work.
Can you just help me understand a little bit the difference between the surgeon, the breast surgeon versus the plastic breast surgeon, or are they one and the same, or are there different roles and responsibilities? And I'm asking in the sense that when I was going through my own surgery, I had what was called or referred to as an oncoplastic surgeon. So he, I believe, was the surgeon who took out and removed the cancer, but then also at the same time was doing the reconstruction piece.
Sure. That's pretty unusual. Probably about 10% of reconstructions are done that way. It's more common to have an oncologic surgeon do the initial part of it, and then the plastic surgeon do the second part of it. I like it that way only because I will tell the general surgeon, the oncology surgeon, do what you need to do. I don't want you to be limited by what I'm going to do later as far as taking care of the breast cancer that she has at the moment. Just leave me what leave me what you're going to leave me, and I can take care of that issue. I think if you're really kind of doing both things as an oncologic surgeon, you may skimp a little bit because you know that if you do or leave a little bit more tissue there, you're going to get an easier result, a softer result. Where I just tell them, do what you have to do. Don't even think I'm coming in after you. And just do what you think you need to do for that cancer. Whether that involves resecting some of the muscle off the chest wall or any of that kind of stuff, I will walk in and I can fix it. It's something that I've worked very well with general surgeons over the years and doing it that way. And they like it because they have full control over what they want to do. And they're not thinking about the reconstruction. The flip side for them is that they take care of you for the initial maybe month or so through the diagnosis. And then as a plastic surgeon, I take care of you for next year. And so they don't have to worry about that part of it. If you start combining them, then they're worrying about both of them.
About everything. Yes,
Yeah.
absolutely. No, thank you for breaking that down. Plastic surgery, like, should we just jump into, like, okay, we remove the cancer and you walk in, you're up, and how do you approach what's next? Or maybe I should back up. You probably have conversations with the patient way before the surgery date to explore reconstruction options.
Yes. And actually, I love doing breast cancer reconstruction. So actually, my office is instructed if we get a call from a patient who has been diagnosed with breast cancer, I see them in 24 hours.
Oh my
Period.
goodness.
Yeah, I want to get things rolling. They don't need to be sitting around mulling all this over. So they come
I hope you
in.
know people are going to be listening to this podcast now, flocking and flying to find you in St. Louis, by the way. Like, that is just incredible.
Yeah, I did. Within 24 hours, I see them. If they call, I see them within 24 hours. Even if our staff waiting, late, staying later night, whatever. I feel very comfortable doing that, and I really feel like the patient appreciates the fact that this is not a time period where all of a sudden they're sitting there, they get no information. Um, I give them a lot of information. Oh my gosh. By that time, we have the diagnosis, we have the cell type, we have a lot of the stuff that I can sit and talk to them about. Just because I've done so many, I'm kind of in tune to it. So I can really help them along with the surgical part of it, my reconstruction part of it, and then the oncologist part of it, whether they need chemotherapy or long-term hormone therapy or something like that. It is something that, again, I feel very passionate about, and so I like to do it that way. It is something, and you kind of hinted at it, there's different types of reconstructions. And I don't know, I've drifted in all different directions. I have settled on something that I think is the best for the patient as far as the oncology part of it, and also the recovery part of it. Like I said, I've done them all. Again, I'm old, so I was in my plastic surgery residency. Was the first time they started to do those big abdominal flaps. But prior to that, we were doing just a direct to implant, where the oncologic surgeon would get done, and we would go ahead and put an implant in. They've kind of drifted back that way again. In between the implant and the using your own breast tissue, we use a tissue expander, which is a device that actually we put underneath the muscle, stretch out the skin till it gets to the size of the implant that we want to put in, and then slip the implant in. So it takes it to a two-stage operation. A lot of people are trying to do an immediate reconstruction now as a one-stage operation. It's not, in my hands, it's not the greatest result. I can get a better result if I have two stages, only because that second stage I can fix what's not right with the first one. So I like having that second opportunity to go in. It doesn't seem to be very prevalent nowadays. Nowadays, probably, I would think if I had to give a number, 60 to 75% are a direct to implant reconstruction. And typically they put it in the mastectomy site, so the same site. And oftentimes they wrap it in a cadaver, what they call alloderm, and then put it in that site. And I get a better result if I can do it my way. And that's, kind of a delay type of final reconstruction, doing something at the same time as a mastectomy, and then coming back and kind of, like I said, correcting my mistakes and putting in something that will give them a better result.
And when you're talking about better result, can you define that for me? Like, what are the things aesthetically or physically that you're looking for?
Just to go two different directions with that. One is if it's only one side, you really do have to try to match the natural side. The thing is that women are not symmetrical anyway. So it's kind of difficult. 80% of women are not symmetrical in one way or another. We try to make them as symmetrically as we possibly can, but it wouldn't be unusual to have somebody who is fairly bigger breasted on one side, smaller on the other side, and you put a smaller implant in, and then you have to do a reduction on the other side. So about 20 to 30% of women have to have some type of a procedure done on the opposite side, if you're only working on one side for the cancer point of view. There was a time period that a lot of women, even though they had cancer on one side, were choosing to do bilateral mastectomies, just so they have that off their mind, because I hear from them all the time that when they go back for that first year, second year, third year, fourth year, fifth year mammogram, it just takes it out mentally on them. And so a lot of women have chosen to go, okay, we'll do both sides, and then I won't have to worry about, every year having a mammogram. So that's not, in my practice, not unusual, and probably only because everybody who works in my office, every female who works in my office will say, absolutely, just do both sides.
Yeah, exactly. I hear that a lot too.
You can't get a real natural breast on the reconstructed side as you have on the one side. And so a lot of people would just go ahead, listen, I'll get the reconstruction done on both sides and then they'll be the same. So that is one of the kind of things that I like to talk to the patient about beforehand. I would say that, the people that I've done only one side on, a good 10 to 15% come back over the years and want to have the other side just done, taken care of. A mastectomy on one side and reconstruction to match the other side. It's always fun when you can make the patient feel good about themselves. And my best story is I had a lady who came in, we did multiple surgeries on her. She ended up having breast cancer on the opposite side. We did some surgery on her. And for one of her post-op visits, she came in a red satin bra. And I was like, wow, she goes, I would never even think about wearing this bra prior to what you've done. And so it gave her that much confidence that it was just a beautiful red satin bra that she had to show me, because typically we have them take their clothes off, put a gown on, and she kept her bra. And I want to show you this because I would never wear this bra prior to the work that you've done. So that's always really a heartfelt thank you to me, if I can do that for a lady, that she doesn't have to worry about that. Again, you talk about two different things where you talk about you can make a lady look very acceptable in a bra and clothes. Having them out of a bra and clothes and without clothes on is a little bit more difficult. And I always tell people, if you're going for that as a goal, then it may require a little bit more touch-up surgery down the line. But if you want to, throw a bra on and put your clothes on and look symmetrical, then we can usually do that in a two-stage operation.
One of the things I have come to notice with surgery is that the surgeon and the plastic surgeon, the doctors, they're all like, oh my gosh, this looks great. This looks fantastic. You're healing well. And I look down and I'm like, oh my God, this doesn't look great. What are you talking about? I am bruised. I'm black and blue. I have inflammation. I'm swollen. I have drains coming out of my sides with these little, like the JP bulbs holding all the blood and the liquid. I'm like, this is not me. This is not what I was expecting. I mean, I don't know what I was expecting, but I think on some level, it's like, okay, we're going in for surgery. We're going to take out the cancer. And I hope to wake up having some resemblance of myself. And I think as the patient, it's really hard to have patience and allow yourself to heal so that you can get back into loving your body again.
Now, I had one lady, big business person, and she had breast cancer, did her reconstruction, and 1 year, she was sitting in her office, one of these big buildings in St. Louis, and she closed all the curtains and she started to cry because at 1 year, all her oncologist is gone, her general surgeon is gone, and she's like left alone. And she said, it was fun because the only person I could call was you. So that's always, kind of heart-wrenching for me to know that you lose all that support that you had, at least initially, is gone. The first time people see the reconstruction, it's devastating for them, absolutely devastating. And then, of course, you go to the surgeon and they say, oh, it looks great. And you go, no, it doesn't. It looks horrible. What do you mean it looks great? And you have to appreciate the fact that that surgeon can kind of see 6 months down the line. You can't. You see it the way it is. The bloody dressing, the drain coming out and blood oozing around the drain and, all that kind of stuff. So it's devastating. And then if you're only doing one side, it surely doesn't match the other side. There's no way you can make it to match the other side with one setting like that. And the patient thinks that, well, that's the way it's going to look forever. So it's always a devastating, that first view. I try to tell, and you said you didn't want anybody with you. I always try to tell my patients, listen, make sure somebody is with you. I've had at least 5 people get lightheaded in the shower the first time they take a look at it. So I want somebody at least close to you that, if you start having an issue, then somebody will be there, whether it's your mom, whether it's your husband, or, whatever. Somebody should be at least close in case you can't contain yourself, because it is devastating. It's totally devastating the first time you see it. And I always, like I said, it always kind of equates to the poor patient before who used to wake up and not know whether she's going to have a breast or not. It's like,
I know.
wow, I just can't imagine doing that.
When a patient chooses to have implants, how do you help them choose the type of implant they're going to select and if it is surgically placed above or under the muscle?
So the general scenario nowadays is to take a regular implant and wrap it up and put it into the mastectomy site. And so it's in the same place that the breast came out of. The theory with that is that you have that mastectomy skin that was a breast, that you've just taken the under part of it out and you put something in to replace that under part, the breast part of it. Um, I have a preference to going underneath the muscle because I've had a few people that have come to me that have had that type of a reconstruction done. And all of a sudden they have a recurrent, and the recurrent is on the chest wall, and that is underneath the implant. And you can't feel it. And I'll go into the lady too that was a little more problematic than that. But if you put it underneath the muscle, if you're going to have a recurrence, the muscle comes up against the skin, and you can feel a recurrence when it's a pea size rather than when it's a dime size. So that's kind of my preference from the oncology point of view. Again, the way I do it with the expander, which is stretches the muscle out and stretches the skin out, is that gives me time also to kind of correct anything that I need to correct that second time in. What do you correct? I mean, the implant might be in the wrong place exactly, might not be low enough, it might be too low. You can correct all that at that second stage and make the result better for you. Um, Implants are interesting. Again, just because I'm so old, I went through all the silicone gel implant controversy in the early 90s, where the implants at that time were truly not anything like the implants we have now. Those implants were very fragile, and about 50% of them broke in 10 years. Nowadays, you get to a 10-year, and most of the implants are less than 5% that are going to rupture or do anything bad. And plus, the older silicone gel was a real viscous type of gel, like a KY jelly. So if it broke, it went all over the place. These newer ones have a highly cohesive gel on the inside. And those you can actually cut in half and the gel goes nowhere. It's like Jello. I mean, they were called the gummy bear implants. The gummy bear implants was a specific implant which had been taken off the market, but that silicone gel is the same type of material that we use now inside our implants that we would use presently. So the gummy bear is off the market, but that same type of the gummy bear problem, just to go into this, was the outer shell, where it was very rough and that irritated the tissue, and you actually could have a cancer develop on that tissue. So in the capsule around the implant. Once you got away from that textured surface on the outside of the implant, you could use that inside gel. It's a superb duplicate for breast tissue. So that's why our preference is to use that. There is another implant called the saline implant, which is a saltwater implant. It has the same outer shell, but the inside doesn't have the silicone gel inside of it, and it's just filled with saline. Now, having said that, there is something not new, but it was at least identified back in the 90s, and it's come up again, and that's the breast implant illness problem, the BII. And essentially, that is where women with breast implants have a lot of the symptoms of an autoimmune disease, and that's joint aches and pains, back problems, things like that. But all their testing for something that is treatable is negative. So rheumatoid factor is negative, systemic lupus erythematosus is negative, rheumatoid factor, and so there are women that have these symptoms that is not a diagnosed medical illness, and so it's kind of put into a category if they have breast implants called breast implant illness. The big issue with that is that it can be both gel implants or saline implants. So it's probably the outer shell that's doing it, if it's doing it. And if you take them out, very rarely does a woman get better. So that's the problem too. So it's kind of like, again, back in the 90s, I took a lot of breast implants out because of people having these symptoms. It was very unusual for somebody to feel even a little bit better. And of those patients that I followed, about 70% of them, 10 years later, wanted to have their breast implants back in. So they realized that having implants out didn't improve their symptoms, and they liked having the implants in place, and so they came back to have the implants put in place. So the implant controversy is going to be going on and on and on. They're developing new things. Again, it's very difficult to say where we're going to go with it, which kind of brings up another topic. Is there was a huge push in the 90s to do breast reconstructions using your own tissue. And it was initially taken from the back and the skin and brought around, and then it was from the lower abdomen. And presently, probably the state of the art is detaching the lower abdominal skin and muscle and blood vessel, and then reattaching it up top. So it's a microvascular. It's all done under the microscope, where you actually detach that area and bring it up and suture the blood supply back in. That avoids the issue of the implant altogether. I said I was going to hint at one thing. I did a lot of those in the day. I stopped doing it for two reasons. There was a lady who came in 5 years after I did that, and everything looked really pretty good. And she pulled me off to the side and she said, "Can I tell you something?" And I go, "Well, yeah, of course you can." She goes, "I would never, ever do this again." And I was like, pretty much blown away, because she had a really good result, really nice result. She said, "What it's done for my abdominal wall, though, I can't ride my horse. I can't work on my farm. I can't take long trips because you're missing that abdominal wall muscle." My second one was a lady did the reconstruction on, and then I got her sent back to me, I don't know, 12 years later or something, by the oncologist, who said, "I feel something funny in her breast area." And she came in and she had um, a 3 by 5 centimeter recurrent breast cancer, but it was underneath the flap on top of the pectoralis muscle, the chest wall, but you couldn't feel it because the flap was covering it, and you typically don't get mammograms or ultrasounds or stuff like that after a mastectomy. So this was missed for years and years and years and years. And so that kind of gets back to what we had talked about before. My preference is to actually put it underneath the muscle, let the muscle come up to the chest where you can feel it, any type of recurrence at an earlier stage. And I don't do the big major abdominal wall reconstructions anymore.
One of the things I wanted to also talk about when you're doing like breast reconstruction, do you also, or maybe this is more for the general oncology surgeon, remove the like the lymph nodes as part of the surgery? And then I know that there's a lot of new techniques now with different types of surgery to prevent lymphedema from occurring compared to what it was like back in the day.
Oh, back in the day, I mean, as the whole goal is to take as many lymph nodes out as you could, so that they could get a reading on all the lymph nodes. Present technology, and it may be a little bit more advanced in the last year or two, but present technology pretty much is that you do some type of either radioactive material or dye into the breast that has a cancer prior to any type of surgery, and then you can follow that intraoperatively during surgery to a lymph node. It's been shown pretty consistently that if you can get some diagnosis with the lymph nodes, with that one, what they call a sentinel node, one node or two or three nodes, that is probably as good a diagnostic procedure as taking all the lymph nodes out. But if you're only removing a few lymph nodes, then you have less of a chance of running the issue with lymphedema, where the arm swells up and you have difficulty using your arm, and they're wearing compression garments and things like that. It was not unusual. Again, back in the 70s and 80s, have a lot of women wearing the compression garments because they have very bad lymphedema from having the lymph nodes taken out. That's really unusual today. I see probably two a year that have that, but in general is that if you get some type of a sampling of the lymph nodes that seem to be the first lymph nodes that would be involved with cancer, and you do that by your injection into the breast tissue, again, it's either radioactive material or a dye, you can take those few lymph nodes out and you can analyze it, and based upon that, it will put you into stage 2, and so that'll dictate the chemotherapy from then on. And you not eliminate, but decrease the risk of having the lymphedema.
Okay,
So.
great. Thank you for explaining that, because I know that's something that is always changing and getting better to reduce the risk of developing lymphedema. But I know that's a concern for a lot of people who are exploring surgery options, and the fear that if they have to have their lymph nodes removed, the fear of developing lymphedema or having other complications down the line.
Right. I think, and one of the things to kind of highlight with the lymphedema too is back in the day, it used to be the great number of lymph nodes we took out. Nowadays, it may be even a small number of lymph nodes, but radiation will do it also. Radiation will collapse and scar down some of the lymph channels, and so you get some lymphedema from that. So it's not unusual for somebody to have radiation and have at least a little bit of lymphedema, even though there are only 2 or 3 lymph nodes taken out.
Mm-hmm. And does radiation impact the type of breast reconstruction a patient would be eligible for?
If you are consulting with a patient and you feel a lymph node and you go, you're probably going to have radiation, then again, I have a long talk with the patient, but I will oftentimes take a step back and say,
Mm,
well, let's do the important thing first. Let's take care of your cancer, because if we do something as far as an implant and you have radiation, that doesn't that doesn't screw it up. On the other hand, it makes it so you're having many more operations afterwards, because
mm,
radiation in the face of an implant will have much more of a scarring effect around the implant, and it'll be tight and hard and firm and not anything natural that would match the other side. If you radiate the abdominal tissue that you've brought up, then it will constrict down and really
mm,
not be anywhere close to it. So if you're pretty sure that the patient's going to have radiation, then it might be better to take a step back. If you take a step back, there is the option, and it's a beautiful option because we've used this so many times, the muscle from the back and the skin from the back, because this all is kind of irradiated, and you bring a big chunk of your muscle, it's the latissimus muscle back here, and that kind of is in there as a very good blood supply carrying tissue. Okay, and that'll help you with the reconstruction. The skin that's
okay.
attached to the muscle will survive, even though some of the other skin you might have to, be leery of. But if you bring that around, again, that was one of the original reconstructions, and it's still the workhorse of somebody who's had breast cancer and has had radiation. The big option at that time is to go ahead with a latissimus flap from the back using skin and muscle.
You mentioned earlier that you have these really close relationships with your patients. How do you establish that?
So, and I always tell my patients, so you can come in and see me once a year for the rest of your life. I don't charge you. A lot of times it's just have a lady down in a little town, probably about 100 miles away. She comes up every Christmas with her friends to go shopping and stops to see me
Oh,
and comes
that's
in.
amazing.
So we talk about what's going on with her, and I do a check to make sure there's no recurrence. But her main thing is to, come up and go shopping and to see me every Christmas for 30 years now, I think it's been.
Oh my
So,
goodness. That's
it's fun.
clearly developing special relationships with your patients. It
Oh yeah,
speaks
yeah, love doing
volumes.
that. I mean, again, the problem with a lot of surgeons is they don't do that. Surgery is the most important thing. The technical part of it is the most important thing. I guess for me, it's never been that way. It's always been kind of the emotional part of it too. So,
I appreciate that. Yeah. You mentioned nipple reconstruction. Can you tell
hmm
me a little bit about what that process is like?
sure. It used to be horrid, where we used to take tissue from elsewhere and use that. Nowadays, it's pretty much any type of local tissue that we can use. We'll make a nipple and then tattoo around it.
Oh, okay.
Um, yeah, I'm sorry.
Oh, okay. So it's both tattooing and using
It's both.
tissue.
Yeah, it can be
Okay.
absolutely both. I'm going to tell you the story because it's kind of funny. But there was a tattoo guy down in New Orleans in one of these district things, and
Yeah.
he started to do nipple areolar reconstructions. I mean,
Hmm.
tattoos. They were fabulous. Oh my God, they were
Yes.
fabulous. Enough that I sent at least two or three of my patients down there for him to do them. He subsequently went on to get some type of an appointment at Hopkins, and he had a little thing just outside of
Wow.
Baltimore. And his daughter, I think, kind of took it over. But I just saw a lady that I did about 5 or 6 years ago that she had her reconstruction or her nipple reconstruction tattoo done by him 5 or 6 years ago, and it was fantastic.
Yes. It is incredible what these artists are able to do. One question we get all the time, and I'd love to know your experience about reconstruction and then even with like the nipple reconstruction. What level of sensation can women expect after these types of surgeries?
So it is more likely that they're not going to have sensation in these areas. And I will kind of explain to you because if you have an implant put in there, the implant will obstruct any of the nerves that are growing back up to the skin. All those nerves are cut when you do the mastectomy. And they have to kind of come back up to the skin and reattach to the receptors in the skin so they can send signals to your brain. That doesn't happen if you put an implant in the middle of that. Now, that's not 100% true in that you get some recruitment from the side, but usually that middle part is really pretty numb, which gets into the nipple areolar area. You're never going to get hypersensitivity in that area. If you get any sensitivity in that area, it's going to be kind of a normal sensation where you can feel touch. You probably won't be able to feel much more than that. So yeah, that's just very typical. There is some feeling that if you use autologous tissue, like your abdominal wall or the chest wall of the back in there, that the muscle will allow the nerve to grow back up to the skin. And I've seen that where you get better sensation in the middle of the reconstruction with the autologist. You're using your own tissue in that area. But if you have an implant in there, it's going to stop any type of sensation from getting there.
Thanks for clarifying. That's really good for our listeners to know. Another question I had for you is with regards to delayed reconstruction. Is that still an option for patients?
It's much less common nowadays than what it was. I would say that in my early practice, probably 50% of them were delayed reconstructions. And now you really don't see very much of that anymore. Although I have a lady right now who actually came to see me preoperatively, diagnosed. Her husband is a radiologist here at my hospital. And she said, I just want to talk to you. I don't know where we're going with it. I don't know what it is. She had breast cancer on one side. She had a little bit of a family history, not a real strong one. Gene negative with all her blood testing. And she said, I just want to talk to you and, come up with some type of a plan. So we talked for a good period of time, and I got a really nice letter from her the next day. But she decided just to go ahead and have bilateral mastectomies at this time. She said, I just want to not deal with the cancer part of it. I'm okay, doing the external prostheses and a bra for at least right now. I don't know. It might change, in a year or two. And I said, unless we have the radiation issue, you really haven't burned any bridges. And it turns out we didn't have to have the radiation issue. So all her options are still open for her. But she was very comfortable in just getting it done, getting it over with, and then dealing with the reconstruction at a later time. And that's not uncommon for people to do. That delayed reconstruction, again, as long as you haven't had radiation, you can pretty much do anything you want to.
And it gives people more time to think and explore options too, right? The most important thing, get the cancer out, and then we'll cross the next bridge when we are able to.
And I always show my patients a great picture. It was a young girl. She was 28 or something like that. And they did a mastectomy on one side and didn't have anything done for 2 or 3 years. He said, I wanted to be free of cancer, make sure I was free of cancer for that time period. I wanted to adjust, my life to know that I'm going to be dealing with cancer for the rest of my life. I don't want to do anything that's going to interfere with the detection of a recurrence. So at 2 years, we went ahead and put an expander in and put an implant in, and she was very happy with that decision that she made. And again, part of it was young kids. I don't want to go through all of this stuff. I got my kids to take care of, so I can deal with it now emotionally. And then if I want to later on, and she did, have her reconstruction done. So
amazing. I appreciate these live case studies and examples of the patient experiences. That really helps us understand all the gamuts that we can explore, the pros, the cons, the options, and all the decisions that go into kind of navigating surgery and breast cancer. We've spoken a lot about the success stories and the positive outcomes your patients have experienced. You recently had a book published. What is the name of your book?
It is a book called Exposing Bad Plastic Surgery and the Secret to Avoiding It. So it has a lot of patient stories. Obviously, I like to tell patient stories because it gives a reality to it. But it essentially is try to expose how people get into those situations where they get bad plastic surgery. And then the last part of it is how to avoid it. It came on Barnes & Noble and Amazon on the last Tuesday, the 26th of November. So it's just out. So.
Well, congratulations on that.
Well, thank you.
Thank you for taking the time to answer all of my questions and educate myself and our listeners, and really diving deep into your profession and passion. So thanks for being here today.
Well, good. I hope I gave you a little bit something more than what you get superficial, because
100%. Thank you.
Again, the patients give me that, as experience, and I can at least relay some of that experience to others.
And thank you, everyone, for listening to our show. I would like to acknowledge that all of the information on our podcast is from personal experiences and is not a substitute for professional medical advice. You should always contact your medical care team. If you are looking for specific topics or would like to be a guest on our show, please feel free to reach out. My email is laura@survivingbreastcancer.org. Our show is made possible by our nonprofit, survivingbreastcancer.org, and by our incredible donors like yourself. You can hop on over to survivingbreastcancer.org to sign up for our mailing list, make a donation, and explore the 400+ programs we offer each year at survivingbreastcancer.org/events. Until next time, keep on thriving.